we're going to be recording this session as well, and the way that we'll focus on this session is that we'll start off by having a brief overview. So I'll just do a brief presentation and overview as to where we are and some recommendations as to what practices should be doing at this stage. And then I'll open it up to the floor for some Q&A. More than happy as we go along for people to start putting things into the chat, and we'll pick those up as we go along. And we've got both Abu Bakr and Mo who are supporting on the administration of this. And two other things, the recording will be circulated afterwards, and because of the nature of what we're dealing with and the changes that are occurring, we've got a follow-up webinar in a month's time as well, just to update as to where we are in a month's time. So that's some housekeeping. So let's kick off. So just by way of introduction, my name is Osman Bhatti. I'm a GP in North East London and the CCIO for the ICB, and I've been looking at this for quite some time and just trying to understand what it is we need to be doing and some of the concerns, and I'm grateful for a lot of the concerns that have been raised either directly through your PCNs or through your place-based IT leads. And what we've looked to do is try to collate as much of that information and try to present something that will hopefully support practices, and we're going to go through some of that now. So let's kick off, and just by way of seeing what we're doing at the moment, where are we now? And I think there's been lots of changes, as you're probably aware, over the last few years, because patient access to records isn't new. It's been around since 2019, but there have been some mandatory contractual requirements that have been put through more recently. So the first thing to just note is that in April, NHSE asked EMIS and TPP to allow practices to opt in early to allow patients to have prospective access to their records. And data that I've got as of August, 13% of NEL practices have decided and opted to go in early, and the go live date is November of this year. And just to have a look at the data in a bit more detail, North East London is 13%, as is North Central London, and it varies across London generally. And also, if we look at the home counties, there are some who are less, some are more. So it's quite varied as per the uptake of how many practices have actually gone early. So what is the actual contractual obligation? And we'll get the slides circulated along with the webinar as well. So I've put loads of links to what I'm going to be talking about in here as well, so that if you want to refer to them. But I'm just going to quickly go over. So what part of the confusion has been the change in language and contract details? Because initially, when we look at this going back to last year, there was lots of discussion around, we must promote and offer patient access to online records, and then that's oops, on my mouse, and then there was some must that was on there, and then things developed around the offer of redaction software, and the contractor, the GPractice, must allow configurations to be in a certain way, and there's been lots of specific things that have been put into the contract and then followed up and been removed from the contract. So it's all a bit of a changing beast at the moment. And the other thing that was in there was stuff around redaction software. So NHS England initially said there was supply redaction software, then that got removed. And EMIS are now providing some redaction capabilities as well. So it's all a bit of a change, really. This is where it currently lands. So the way that the contract reads currently is the fact that practices need to be providing prospective medical record by the 31st of October, and whichever is the earliest, 31st October. And if you look at the last number 7 is where practices haven't done that for whatever reason, the patient, if they make a request in writing, must be provided with that facility. And we need to look at how we manage this within North East London. So there's the link for those details there. So both EMIS and NHS England have written to all practices to sign up, and I think the first thing to say that it's not contractual, and that's the bit that's been lots of toing and froing about, and we've discussed this with the LMC and the BMA. The main focus that NHSE have is that patients don't have the 104 globally applied, really. And then the BMA have updated local LMCs about this as well. And I've just taken an extract from what the BMA have said, and this was the notification that went out to LMCs, and there is certainly some ongoing concerns that are still existing in here, and that practices need appropriate time and resources. And this is a recent update, so I think the feeling is that practices are inundated with lots of things, and they need time and resources to do this. And the fact that I think the bottom line is to reassure practices that they do have time to consider matters on this. And the BMA have also said that they are going to be putting out some further guidance as well shortly. So we're waiting for that. But some of you may have received this already. So this was an email that asked practices to opt in. And I think the first thing to say is that there are effectively two things that practices need to do. One is to ensure that they've gone through the readiness checklist and they are happy with that, and they are happy with the guidance around redaction as well. So I think the first thing to note is, particularly if you're looking to go early, is to make sure that you are aware of these commitments really that you're committing to. And again, I've linked this in to the document as well, really. So there are a whole load of policies and processes that practices should be aware of. Staff should be fully trained on a whole load of things. There's webinars that NHSE have done. There's a clinical safety case report, which is about a year old and has again caused a bit of concern because it mitigates a lot of risk onto the GP practice, which I'm going to come to as well shortly. There's a whole section around staff being aware, and part of the way that I'm hoping we can do this is to try and get every staff member to effectively download the NHS app for themselves and see how the app works and what can and can't be accessed. And the other thing is that ensure that prospective access is being promoted and offered. And I was at a meeting earlier, and one of the things we want to try and do is like to get some material out to practices so that practices can display in their practice waiting areas something around letting patients know that if they want prospective access, it's available for them, or as a website banner on their website. So just so that patients have got awareness really, and I think that's part of what we're looking to support practices with. So there's a link to the document I'll embed into the presentation. Now, one of the things that is there. Whoops, I think I've just lost my sharing. So let me just go back into sharing. Second, here we go. Back onto here. And then share this again. So one of the things I want to just show with you now is the actual EMIS redaction advice, and there's a link again I've put into the presentation here. So what we should be looking at is making sure that all of our practice staff, so these are clinicians, admin staff, people who are handling documents, and also this extends, if you look at the clinical safety case report, this extends to locums as well. So anybody else coming into the practice, they should be aware of this. And I think this also presents some challenges. This is something that practices should go through. And with consultations, there are ways that we can omit the visibility from patient's record. So if we have a look at a patient, you'll see on the menu bar above, there's this online visibility icon. And what clinicians are advised to do is, if they feel that there is something that may be not appropriate for the patient to see in the online record, they should be marking this as they go along. So as they are consulting from now onwards, or from wherever you go live onwards, they should be marking a consultation as either the default is it's visible, but if they do not want it to be visible, they mark it as such. So that's one of the key things for clinicians to be aware of. The other thing to be aware of is within the care history, you can do the same thing. So there might be a whole list of things in the care history. And again, you can right click on one of these, look at the online visibility, and again, mark it as do not display on the patient's online care record. And wherever that's marked, you get an icon that's displayed by the side of it. And this is something that might be worth doing. So for example, in your practice meetings, just to go through a dummy patient and mark things as do not display and see how it actually looks so that people are aware. You can now do it in medications. One of the concerns was you can't do it in medications, but now you can. So when a drug is added for the first time, you can mark it as such. And again, this might be relevant for some patients. And for existing medications, you can do the same. And then here's just a screenshot of that. There will be a mark on the side that it basically indicates the fact that this medication is not going to show up in the patient's record. And there's a whole load of other information in there. I'm just going to scroll down. There's some updates that are coming in where you can also do this to investigations. So if there's investigations you don't want to share exactly the same way as well, and with referrals and with documents. So what EMIS have done, and similarly with TPP, is that in every aspect of the clinical record, they've made it possible to mark something as not to be visible to the patient on their online care record, which does go some way to help, although it doesn't quite answer the issue around, how do I screen all of the documents in my practice for a particular patient to ensure that there's nothing that I need to redact. And that software that doesn't currently, well, it does exist, but it's not currently funded very easily from anywhere specific. I think that's something that we need to just be mindful of. So the redaction, I think, is really important. And one of the things I really want to stress is that whatever happens with the guidance, we should be aware that all our clinicians, anybody who is scanning the record or basically putting anything onto the clinical record, is aware of how they should be marking redaction. And what we've done is that we've got all of our IT facilitators working on this. And if you need some support or for someone to come into your practice, effectively, we've got that support that can be provided to practices. So if you feel you need some support for somebody to come in to go through that with your staff, then definitely make sure that you link in with the facilitators, because we've really stepped up that provision for all practices. So that's that. I'll just pick up. There's a couple of comments that have come in. I'll try and pick things up as we go along, actually. So really important to make sure staff know the difference between online visibility and confidentiality. Brilliant piece. So yeah, that's a really good point, because there are two options that sit side by side. One is online visibility and one is a confidentiality policy. Now, the difference is that the online visibility is what the patient sees. Confidentiality policy is what other members of the staff see. So if I've got something in my record that I don't want my reception staff to see, and I only want the doctors to see, I mark a confidentiality policy, which will still be applicable to the patient. But if I want a patient not to see something, I mark it as online visibility. So just be aware that you know the difference between online visibility and confidentiality policy. They're two separate things, and we're aware that we mark them both, because I think one of the issues has been the fact that these functionalities have been rolled out quite close to each other. So when you see one, it's easy to get things mistaken. So just be aware of those two. They're brilliant question. The other question is, can a patient challenge the visibility if they find things are missing? Absolutely. So I think it's when you're redacting anything, you need to be able to justify it. Typically, the stuff that gets redacted is, for example, documents that have third-party information on, or have details of a third party that you don't want the patient to know about, but you want it to be held on the clinical record. So as with anything that you redact, you need to be able to justify why you've redacted it. Generally speaking, by and large, the vast majority of patients will not have much redacted. But if they do have something redacted, then you need to be able to qualify why. And I think that's another thing that we should be mindful of, really. And Ray's made another really good point in the consultation, that if a patient makes a SARS request, it will extract basically if you're printing something out on a SARS request, it'll basically show everything. So one of the things to think about, and one of the things that I've been advocating certainly locally, is the fact that if a patient makes a SARS request, think about why is the patient making that SARS request. And usually if you provide them with online access, that overcomes the issue, because essentially a SARS request is made because they want to see what's on their medical record. And if you provide them with online access, that's a way that you can avoid having to print out reams and reams of stuff. You can just say, here's your online access, and I'll go through a process as to how we can do that later on, and then provide that to patients as well, really. So that's the redaction bit, and again, that's going to be quite a topical thing, and we can pick that up later on in a discussion. Now, the issue with prospective access is quite a lot. So I've outlined where we are. I've outlined the readiness checklist and what NHS England want us to do and what the BMA have said. So there are several issues, and part of this is who actually has access. So if this is automatically enabled, we need to be careful about who's got access. So patients who have mental health issues will get access. Patients under domestic violence will have access. Any coercion or people with capacity issues, all of that will be accessible, and sensitive information such as certain diagnoses. So there are certain issues that have been raised by colleagues locally and nationally around going live with this en masse effectively. So one of the things we can try and do to mitigate some of this is to run some searches to try and exclude some patients. So I'll talk about how we can do that. There is no redaction software. So I've mentioned, yes, there are redaction facilities, but the software to go through a whole list of documents and redact automatically isn't there. And the other big thorny issue is who is the data controller, because it should be the GP practice, but actually if it's being automated, is it actually NHS England? And again, we haven't quite got an answer for that. And the latest I've got, if you ask NHS England, they will say the GP practice is still the data controller, which begs several questions, which I'm just going to pause. I'm not going to go into. So there are several changes of goalposts that have occurred, and I think we need to be thinking about what is it that we can do to try to mitigate some of this. Some of this is happening nationally, because one of the things that has been a major concern is that if I'm a patient at one of your practices and you've redacted a whole load of information from my records, and then if I join another practice, all of that redaction gets taken off, and there is no transfer of the redaction codes. Applies mainly for retrospective access, doesn't apply to prospective access, but it's still a significant issue. So there has been an update on that, and the most recent update is that there has been a new update to GP, and it's I haven't seen this. I don't think this has gone live. I haven't seen it go live as such. If anybody can correct me, please do. But the plan is that actually transferred with GP to GP, which then makes it even more important that we are using GP to GP to transfer records between practices as well. So just another thing. And again, our facilitators are really well versed in GP to GP, and if you need further support on that, absolutely get in touch with the IT facilitators, and they will support you in GP to GP. And for the benefit of GP to GP, they have looked to improve things, and there is much better transfer of information, and the flexibility to allow it with bigger timescales has been provided. So the fundamental message from NHS England, and there's been lots of discussions back and forth, is that practices should be checking their global settings, resolving any bulk 104 codes, and looking to, again, I've linked to a document to look to how you resolve those bulk 104 codes. And when I present this to lots of practices, the common themes that come back are these, and that's that, I've mentioned some of this already. The access, if it's automated prospectively, may not be to the patient who the record's about, because certainly in areas where there is high deprivation, we have patients whose medical records are accessed and looked after by other third parties, say spouses, children, for example. And I think there's a significant concern locally about that. And also the fact that the email addresses and mobile numbers we've got on our records aren't often the relatives, they are another proxy. So again, when we're looking for verification of information, it may not be the patient's details. And again, that's a concern if things are automated. And yes, there are good searches available to pick out those who have safeguarding codes, but not all patients with safeguarding concerns are coded, so may not be picked up by the search. And the other big concern that practices have fed back is that there's a high element of staff turnover, and that's non-clinicians, so reception staff as well as clinicians, and the use of locums, which makes this whole process quite challenging. And again, for reference, I've just placed some of the new codes that has been provided to support the coding for this prospective access. And I think that this is one of the big confusions that has arose, because there have been so many codes that have come out, and to fix one thing, another thing's been brought out, so it's become a little bit more confusing. So what we've done is that we've built a set of practice support searches that practices can look at. And again, I've linked this to the presentation that you can have a look at really as well. And this is essentially the search. And the first two are the ones that I'll probably encourage all practices to do. And the others I'll talk about as well. So the first thing, if you run this search, there's a whole load of searches, but there are some that marked with action, and the action ones are the ones that I would like practices to focus on. The first one is around actually where the patients have no online access and no prospective online access code. So these patients may need to have a review of the record. So are these patients those that need a 104 code or not? So these patients automatically will get prospective access when they join your practice. And currently, as it stands, the code is there as a marker. It doesn't really do anything as such, but it will help you support which patients have got what codes. So it's worth reviewing these patients. And some practices have just said, we're going to just mark anybody who's coming in with a 104 code, so we know who has access, so we can we've got an identification of whose records we need to be reviewing. The other search, and I think this is probably, if there is one search that you run and action, it's probably this one. So these are patients who have got a 104 code, but already have online access to your patients. So these patients have online access. You probably don't have a concern because there's been some process that's gone through your practice to give them access. So actually, they don't need a 104 code. So these patients will need what we call a 106 code applied. So this search will pick out those patients, and then you can mark them with a 106 code. Then we've also included the search that was done by Bath and Somerset, I think, who are the early adopters for this process. And they basically built a search to basically identify those who may lack capacity, who it may well not be appropriate to have prospective access for. And there's, again, I'll put the link in if you want to read about what they did in the early adopter site. But we built that search into here. So those patients who basically may lack capacity but don't have any codes, so do you want to consider coding them? And also those patients who have got online access but they've still got a 104 code, again, you may want to look at those. But by far, I'll look at the first two. I think the others are more for detail, really. So if we build on that, I think the thing to think about is that actually anybody who has got a previous 104 code was initially thought it would not affect access, but now the guidance is that it may affect access. So again, it's very unclear as to what the guidance is. So it's probably worth just running that search just to make it clear on your coding that patients are actually, if they've got online access, just remove the 104 code. And what that will also do, that will take away the fact that you've got 100% 104 codes across your practice. You can basically take off the ones that have already got prior access, and then you've got a smaller cohort to look at. And we've put together a suggested practice process. So this is a process that several IT leads across North East London have discussed, and this is what we've come up with, really. So the first thing is, as a practice, look at your global coding. Now, EMAS Manager within EMIS has got a default code for your online access. Now, NHS England want this to be the 1st of January 1900. Now, you may say, if it's for prospective access, why do we want it back then? And I think this is very much because the next step, once they've got prospective access, the next step will be retrospective access. And if we're giving retrospective access, then you need to have the date back in time. Now, this has been contentious, and if practices feel that they want to set this at a different time, but that's fine. I don't see a problem with that, as long as practices are consistent with their approach. So the guidance is set it all the way back to the 1st of January 1900. Some practices have set it to the 1st of January 2020 or 2010. It's what are your practice structures comfortable with, and in terms of how far back do you feel you're happy for. If patients want retrospective access, how far back would you feel comfortable? Do you want absolutely everything, which is fine, and which is 1900, or do you have a certain threshold where you feel actually at this point in time we were absolutely confident of all of our records being accessed? And by and large, that works for most patients, generally speaking. The other thing that we've done for practices is to provide a Accurex Florey. So all North East London practices have Accurex as a SMS messaging tool, and what we've done, we've set up a Florey, and I'll talk about this a bit later on, but it helps to prevent practices having to give patients a paper form to say, fill this in if you want to have online access, and then we'll scan that onto our record. This basically is a digital way of automating that paper method, and credit to Having colleagues for supporting us on setting this up. And the third one is to make sure that actually, whatever happens, again, make sure you have a clear pathway within your practices for patients to request access, that both patients and staff understand. And this is fundamentally just to try to ensure that all your staff download the NHS app and use it. I think that's the easiest way to get people aware of how to use it, and then to make sure that you've got good processes and protocols, as has been outlined, to make sure that patients who actually request online access, there's a clear process within your practice. And again, that's a process that the IT facilitators will support with. This presentation will be circulated, so don't worry about putting all your emails in, because we will circulate it if you've signed up on the Eventbrite. So what we've done to make the patient process quite easier to understand, we've put one down as a suggestion. So just to make the guidance a little bit more simpler to understand, if a patient requests access, what would be a good way of doing it? And this is what we've suggested. So step one is that the patient requests online access. So I, as a patient, come to your practice and says, I would like online access, please. The practice would then issue a Accurex Florey, which has all the information on it. And again, I've linked it here. And what that does, so previously you might have said, here, please, dear patient, please fill in this form and bring it back to us, and then we will process it for you. Here, you're basically just doing this through a text message, effectively. And so the patients will be asked a series of questions, which they will have to understand. So, you may see abnormal results, they're about you. Can you confirm that you're not being coerced? So there's all of these assurances that the practices may well want to have documented before they release the record. And once the patient has completed that and sends it back to the practice, then the Florey automatically gets saved into the patient's record. So all the responses gets saved into the records, and then again, it's up to the patient whether the patient then wants to verify the identity. So if you're still concerned about actually, is this patient really who they say they are, you may want to ask them to come in for further ID. And again, that's up to the practice to determine what they want to do, because they have to effectively authorize this patient's request. So once that's been done, it's suggested that there's a code that's added, and this is a code that could be added, which essentially patient registration data verified. So you've verified the patient's information, you've coded that, and that could be a code that you could search against. And then you can either give the patient prospective access at that point of verification, or you can inform that the request will be processed within a set time period. And that's probably more relevant for patients who are requesting retrospective access, which isn't part of this contractual requirement. Contractual requirement is prospective only, not retrospective. But undoubtedly, once patients see something, they may want to see what else is on their record. So this is just to catch that capability as well. And then it's up to the practice what they do. And I think it's very much it's in the practice's gift to set a process for themselves, because all practices are busy and they have to ensure they've got capabilities and capacity to do this. Speaking to practices, generally speaking, practices say that they can turn something around within 2 weeks. Some practices that actually, for us, it's 4 weeks. So whatever it is, aim for 2 weeks. But if you feel that isn't possible, then have some flexibility. And in the time, it's reasonable to review things like the problem list and make sure things are coded, and maybe things are linked properly, and you've marked any data that you want to withhold from the record as such as well. So it gives you the flexibility to do that as well, really. So it's basically having a process for not just prospective, but retrospective as well, which is what most patients are going to benefit from. So if I'm going to summarize what practices should be looking at, it's the following. It's basically to download the searches and to review the codes. It's to download the Flurry, which is an online questionnaire, and then just implement a process, both for yourselves and for your patients. And again, let other practices across your PCN know what you're doing, because it'll be good to ensure that we're doing things together, and if there are any problems to flag it, really. And the main focus is, if you are looking to go early, then absolutely make sure that you've ticked the boxes and you've gone through that. If you're awaiting to go live from the 1st of November, we'll support practices in that, and we'll just work up towards that requirement as well. So that's the end of the presentation, the outline that I wanted to impart, and this information will circulate for you. And I'll just open it up for further comments and questions. So feel free to pop your hand up or type in the chat. I'm just going to go through the chat, and if there's anything I missed, then please let me know. So let's go through. So Alexander's mentioned we've got a query about a sibling contacting the surgery, concerned about a patient's mental health, and then found out to access records and getting access, I suspect, for that patient, and didn't want to know that she had contacted the surgery, and that's really difficult. So if a patient relative contacts you about a patient, then good practice is that you do document it, and then ideally tell the third party that actually this is going to form part of the medical record, and patients may well find out about it, but you can withhold it if it's deemed sensitive. So I think that's probably what we should be doing, and it's a really difficult, tricky situation. But you're right, if a patient then requests their record, or they go to another practice and request their record, that data may well get shared, really. So that's a tricky one, actually, and we just need to be really mindful about dealing with it at the point of the third party asking us, really. I thought patients only see the records from the day we go live. Yes, so essentially, if the patients go live, so the day you go live, or if you don't, it'll be the 1st of November, and if you don't, it'll be the day that you grant access. At that point, they will see prospective only. But if I'm a patient and I come in and I see prospective only, and I want to see what's gone on, a few months ago, then I'll have to make a request separately. And I think that's the concern that we need to just be mindful of, and for practices to be ready for that, because once they get prospective access, retrospective access will certainly follow, and we just need to be mindful of that. The searches, it would be linked in, and actually I'll put the link, or if one of the facilitators here could put that link on, I'll try and find. Searches are on this page, so I'll put that into the chat actually, the link that you can download the searches and the florries on as well. And anything else in lots of things about that? Did somebody have a hand up, or I'll keep going through the comments? When we go live, what can patients who currently have access see? Do we change settings individually? So at the point that you go live, or the 1st of November, patients will only see automatically, will see what is on their record from that date onwards. So if they haven't consulted, they'll see nothing. And again, patients might be wondering, I thought I could see stuff, and the words prospective and retrospective are sometimes quite difficult to get your head around. So patients may expect that they see something when they don't, and may come to practices to ask for that retrospective access, really. How do we go about accessing additional support? The best people to contact would be the IT facilitators. So each place has a IT facilitator that we can link in with. I'm more than happy to be contacted as well, can direct you, or we can get one of your facilitators to support you in that. Nusat?
You're right. Just a quick one. Where can we download the Flurry questionnaire to send out to patients, please?
So it's the same link. So on that link, it's on there, and this is on the new North East London portal, really. So what I'll do is I'll just show you on the screen here. So that link that I've just shared below, that will take you to this page. You can download the EMIS searches, and again, I've outlined the what I've discussed in the presentation I've put in here as well. And then you've got the link to the Florey questionnaire here as well. So that's all on that link that we've discussed earlier, and the process is more or less what I've talked about in the presentation as well. So a summary is here as well.
Thank you.
Any other comments or questions? I know we've got colleagues from outside NEL as well, so welcome to ask. You don't have to be from NEL to ask a question. So pop into the chat. And the other thing I'll just highlight is the fact that I think one of the biggest concerns has been what happens if we don't go live early on. And if you don't go live early on, I think there's ongoing discussions as to what essentially happens. But when I showed you what the contractual requirement was, it's very much about practices continue to ensure that they are publicising access. So basically, anybody who comes into the practice or contacts the practice can have an opportunity to see that actually the prospective access is available. And if they don't have that access, then the practices have got the facility to enable that for them. And one of the things you may want to discuss in your practice is whether patients will just get prospective access, or whether you want to look at retrospective access as well. And it may generally be worth looking at both prospective and retrospective access, because it kind of will sort that patient out, and it'll be dealt with at one point rather than several. Dimple.
Hello.
Hey.
Hi. So we have a question about patients who already have online access. What can they see, and what else was it? What can they?
have to redact their notes from the 1st of November, let's say. Let's go live date from then.
Yeah.
Or
so
and they see everything from now, because at the moment they have online access now. Actually.
Exactly, and I think that's the issue that has been debated, really. So essentially, anybody who's got online access today, this shouldn't affect them. and they will continue to get online access as per the normal process. What practices should probably do is that all those patients who have got online access, when you run through the search, just take off the 104 code from their record. So just apply a 106 code. So one of the searches looks at those patients who've got online access. You just apply a 106 code, so that because there was a query that was suggested that if and when EMIS run a script on your records, they will take away access from anyone who's got a 104 code. Whether that will apply to patients with existing access, it's not clear. So on that basis, just mark them as 106, because the last thing you want is all your patients who've got existing access to come and say, I've lost existing access. What can they see? They can essentially see what you've configured your EMIS manager to see. And the guidance is that patients should be able to see everything. And when we talk about prospective access contractually, it's from a point in time, they see everything. And everything is essentially consultations, free text, investigations, documents, all your comments. They will see absolutely everything on your record, unless you have marked it as confidential, or you mark a date either globally or in your patient's individual record to say can only have access from this point in time, which is where it gets really, really complicated. And I think this is where I think if you look at how this has been managed, anyway, there's ongoing concerns about how it can or can't be managed, and I think that's why we're waiting for ongoing BMA guidance on this really going forward.
I think our main worry will be that when it's challenged, the challenge will be patients saying, well, I didn't say that. That didn't happen in that consultation. I want that taken off, and which we can't.
Yeah. You can't do that. So essentially, yeah. And I think you're raising a valid concern, and this is a concern, particularly for retrospective access, but also prospective access. You enable a patient on the 1st of November, on the 1st of December, they have a consultation. They will then see it and then come back and challenge that. Absolutely. And I think, if that patient did not have online access, then you would have the flexibility to have offered online access to them and had an opportunity to say, actually, I know this patient is somebody who may not be appropriate to give out online access for that reason or whatever. They want to challenge every single diagnosis, and you would want to do that mindfully, whereas this process, if it's automated, doesn't do it. So they're the kind of patients that I would say just apply the 104 code to. And again, if you're unsure about which patients, the practice backup is to apply the 104 code, and you've got some comfort with that. And then anybody who has online access or requests online access, then certainly you can mark them with you can give them access, and you can review the record and be comfortable with it. But it is you're right, it's a mess, but the legal document is the clinical record. They can't remove it. We can make a comment to say why we might have deleted something, but you can't remove it once it's formed. No. Legal document. Thank you. Amina? Going to come off mute? Otherwise, I'll come back to you in a minute. Sharon?
Yeah, sorry, can I just check, does EMAS Manager trump individual patient settings?
So EMAS Manager, so IT facilitators, if I get this wrong, let me know. But EMAS Manager is your global setting, and then your individual patient setting overrides your global setting. I think that's correct, and I'm sure I'll be corrected by my colleague if that's not correct. Yeah, that's correct. Yeah.
Right, so patients that have current online access, very limited read-coded access, problems, immunisations, etc. Once we switch on the EMAS Manager settings, we still need to individually give those full access, don't we?
So if those patients don't currently have that, and you feel that is appropriate, then yes. My argument would be, when you were initially setting that patient up, you probably had a thought or a process with your practice to say that we are only going to be allowing this access. My my view would be that those patients, because they could be a whole lot of work that you're going through, enabling individually, you would keep things as they are with the status quo. And if patients say, well, I can't access documents, for example, then you review it at that point and you allow it. Otherwise, you are going through every single record with those who already have access. And I think that's a concern. Whether the script, when it's run by EMIS, whether it overrides that particular aspect from a particular date in time, I'm not clear on. And I think that's the bit that we're still not sure on. And it may be that that does not happen, because I can't see how in the configuration that would be overridden. So it is a concern. And you just raised a good point, as many other practices have with other points around actually that there are lots of lots of issues where it'll be problematic, and that's one of them. So I would keep the status quo, and otherwise it's going to create a whole lot of work if you've got to go through every single patient.
Yeah, thank you.
Anisha.
So I have downloaded the search that you've just provided, and where I have got 104 code and current online access is live, action for the practice is to take that 106 codes to be applied to these 104 codes. So I've identified, say, 59 patients.
Correct.
I have to code them as 106 codes. Is that correct?
No, you don't have to call them. You don't have to call them. This is just a code on your record. So I will just go through that search, and then you can just mark those patients because they already have online access. The 104 code is essentially saying these patients need to have a review before online access is granted. So you're basically saying, actually, these patients have got online access. They don't need to review. I'm going to mark them with a 106 code, and that's the bit that you're doing with the search. So absolutely, just code them, but no, you don't have to contact each individual patient to say I've marked this on your record. I think this is where we've got to be a little bit more pragmatic around actually supporting practices to do what they can do without creating additional work that's not required, because that's going to just take our focus away from one of the busiest times of the year, really, because November, December, January is going to be busy. Is that okay, Nisha?
Yes, that's fine. I didn't mean that I wanted to contact the patients. I just wanted the action to take is just to mark them as 106.
Just mark them. Yeah, absolutely.
Yeah. Okay, thank you.
Thank you. Here we go. Let's go back through some questions. So Halima, confused about if a patient has a 106 code applied, will it automatically have access or submit their consent via Accurex? So the whole codes is it's only effect. So we are coding for a requirement when EMIS will run a script. Now, EMIS have said we will only run a script for those who are going early. They haven't released any other dates. I suspect they may well release some dates. And if they do, we are preparing for that. If they don't, then we should have a process in our practice to allow access when patients request it. And I think that's what we need to be focusing on. But the coding is very much for letting EMIS know when the script is run. Is it a 104 code? Don't provide access. Is it a 106 code? Provide access. That's essentially what we're doing with the coding. One of the confusing things at the moment is if on the 1st of November, our EMIS is going to run a blanket automation for all practices to have a script run to enable the access. I doubt it, but let's see what they come up with, because they haven't declared what they're doing from the 1st of November as yet. As it states in the contract per se, if for whatever reason practices have not got things enabled, they should be promoting it, and they should be allowing patients to have the facility if they request it. And I think that's what the guidance has been really pushing through, and what the process that I've outlined. Right to rectification, Sheba, I'm not sure somebody shared their screen, so yeah, that's fine, thank you. Sheba, I don't know what you mean by right to rectification. Do you want to expand on that? if an elderly patient is using her daughter's mobile number, how can she access her own records through the NHS app? So yeah, so one of the things when you download the NHS app, there's a whole lot of verification that has to be gone through. One of those verifications is the patient has to basically authorize themselves on the app. And one of those authorizations may be a mobile number. And if the mobile number belongs to another person, then that verification doesn't go through properly. So you need to just be really careful about actually how patients can download and use the NHS app, and part of that is having the right details. And you know, this is one great example of where actually patients have got other people's numbers and details on their record, and verification will therefore be an issue really, unless the other option is the patient comes to the practice and asks for online codes, which again is another big piece of work for the practice. And I want to try and avoid that, because what we're looking to try and do is encourage patients to download the NHS app and use it themselves, and if they want medical record access, we send them an Accurate Explorer that they can get access to. But if the patients have got other people's details on their record, that process does become a little more trickier, and therefore makes the automation or prospective access a lot more challenging, which we've got locally, I think, as well. We've got consultation right back in place. Will that be hidden? So consultation right back, if it's in your clinical record, then it'll be shown. If it is a shared record and it's pulling through a shared record, then that won't be shown. So with right back, it's going, as I understand it, it's being copied into your clinical record, so that will be visible. So Shabnam asks, for retrospective access, do you offer everything from a preset date? So retrospective access, it's up to the practice's gift as to what you offer, and many practices have done various things. I generally, my view is that if patients want access, let them have access, and set it from your practice in terms of from what date do you feel comfortable with that. Because I think if you're not offering access, then they will either raise a SARS request and get something in paper form, which may be more tricky, and it might be better just to offer that as a online accessible option through the NHS app. Can patient access tasks sent internally? Good question. I think the answer to that is no, but again, correct me if I'm wrong, dear facilitators.
Definitely not. No.
Not, yeah, so no, they can't. Thank you. And there's yeah, so thank you, Rena. Is that the NEL team are going to be offering some information governance details as well, so be further webinars we can share, and that's mainly around the governance about who has access to what records. Do we have to notify patients that they can get online access? So that's the promotion. So patients who are coming into your practice will go to your website. Ideally, there should be a way of them seeing that actually this is available as an option for them. And that what we're looking to do is to try to get our facilitator groups to come up with a way of providing all practices with that. So either in poster form or as a banner for their websites as well. Prospective access protocols are the templates that can be shared with practices. So one of our IT facilitators, Raymond from City and Hackney, has put together some really amazing protocols, which where we've launched in City and Hackney, but we're going to be getting those circulated more widely. So we're just going to run those, and that might be something we present further in the October webinar. So we'll put forward some other protocols that you can use within your practice as well. So hopefully that will be available for practices across North East London next month, and we'll circulate those through Resource Publisher. In regards to promoting online access, is there a poster or leaflet? Yeah, and we'll get that and we'll circulate through all practices. And the way that we're looking to circulate information is through primary care comms as the main focus, but also the other two ways that we're circulating information is through your IT leads. So each place has an IT lead, a digital IT lead, and if you're not sure who that is, again, just touch base with me and I can put you in touch with them, because they'll be the main people I'll be discussing these things with. And also I'm going to try and get it through your PCN CDs, or somebody in your PCN will be the rep responsible to support dissemination of information. So we're going to try and get this out to practices via different ways. But if you're stuck, contact the digital team. I'm more than happy for you to contact me directly as well. Okay, thank you, Sheba. Will patients see alerts on their records? When you say alerts, they won't see the major alerts on the records. No, if that's what you're talking about, Anthony, just clarify if that's not the case. Can patients see the referrals done? Yes, because the referrals will be in the document section, so they will see what's been referred. And that's one of the other issues that hasn't been cracked, and that's where you might have gone through your records and you have taken off in the problem list, you've removed some diagnoses, you've hidden some diagnoses, you've hidden the medications, but in the referral letter to secondary care, all of those diagnoses will be in there. And if patients have got access to the documents, they will show in the document. So this is where the I'll keep my thoughts to myself. Let's just see what happens. But it's not that is the problem. So with the referrals, and patients can see. Andrea, there's a video on YouTube, but we're unable to download it. I think which video is that? The NHS app video, and I think one of our digital colleagues has worked really hard to get a video that explains the NHS app. That if you've got a patient screen in your waiting room, you want to play that video. It's with subtitles, and it works really well. I think we've put that onto. Let me just see, because we've put that onto our portal. So the portal again is a really nice place for practices to find information about various things as well. And there are really good resources here. So in the chat, I'm just going to put the video link for if you want to put onto your waiting screen. So there's some really good information on the portal around that I've linked in. Some internal documents cannot be accessed by the patients. So Aisha, do you want to just talk about what kind of internal documents?
These are the discharge letters that come in from their hospital. They come in like the path links, and we've had quite a lot of our patients who's actually phoning us up and asking us, we can't see this, and why are you hiding it? So how do we overcome this?
That's a really, really good question. And this is slightly outside of this, but is part of this as well. So these are documents that come down the links, mainly from Barts Health and also places like Moorfields and UCLH, which are in a format called Kettering. So they ending in KET. Those, if you try to save them or you try to allow patients to view them, they cannot view them because they're not in a format that patients can see. Currently, the only way patients can see that is by effectively downloading it and saving it as a PDF and re-uploading it, which is a pain. We're working with Barts Health to try to get those converted into a PDF, so it comes into the clinical system as a PDF. But that is, again, that's another problem at the moment, that those documents can't be seen by patients, and we're working on trying to get that resolved. I'll update your IT leads on that once we've got a solution. But again, another really good point about information that's difficult to access. I think that we're virtually there now. So if there are any other comments or questions, absolutely feel free to email me, and we can keep this conversation going and try to get practices confident in the way that they are actually using online access for their patients and medical records specifically. We're going to follow this up with another webinar in a month's time, when hopefully we'll have a bit more information, and also the protocol will look to have published by that point as well. And a quick question from Emma lastly, can I ask a question? Is a risk patients will see blood results before the GP? So anything that comes down into your clinical system as provisional is not visible. So only until you go through your workflow and you mark it as read, and then it comes off as provisional, then the patients won't see it. So if it's provisional in your clinical system, patients won't see it. Hope that helps. And on that note, thank you all very much, and look forward to seeing some of you again in a month's time, and feel free to contact the digital team or myself for anything else. Thank you.
Thank you, Usman.